Hello, this is Dr. Gary Siskin, and today I'm going to be speaking about pelvic venous disease. Before any lecture starts on pelvic venous disease, you have to have some understanding of chronic pelvic pain. This is defined as non-cyclic pelvic pain or heaviness that persists for greater than 6 months. And this is a big deal. The prevalence in the United States is 15% in females aged 18 to 50 years, and it can be up to 43% worldwide. It accounts for 20 to 40% of outpatient GYN visits. It's responsible for 15% of all hysterectomies and 35% of all diagnostic laparoscopies. And the direct and indirect socioeconomic cost of chronic pelvic pain approaches $2 billion per year. The list of potential causes of chronic pelvic pain is long. When a gynecologist looks at this list, they see the most common entities causing chronic pelvic pain, and there's a lot of attention in the lay press and online about these common entities. However, when an interventional radiologist looks at this list, they tend to see pelvic venous disease. And yes, pelvic venous disease is an underdiagnosed, underrecognized, and underappreciated cause of chronic pelvic pain, but it may still be a relatively rare cause of chronic pain, even though its manifestations can be found in 30 to 40% of patients visiting a gynecologist for chronic pelvic pain. So before we get into a full discussion about pelvic venous disease, I think it makes sense to review the normal venous anatomy of the pelvis. Without understanding the anatomy, you can't really understand the causes, contributing factors, and consequences of this disease. The pelvic veins are made up of 4 interconnected venous systems. This includes the left renal vein, the ovarian veins, the iliac veins, including the common external and internal iliac veins, and the superficial veins of the lower extremities. The left renal vein runs from the kidney to the inferior vena cava by running in between the aorta and the supramesenteric artery. It receives blood from the left adrenal vein, a branch of the inferior phrenic vein, branches from the ascending lumbar and hemiazygous veins, and the left gonadal vein. The ovarian veins originate from the pampiniform venous plexus and the broad ligament on each side. From there, 2 veins typically ascend on both sides of the corresponding artery until they unite to form one trunk prior to its termination. The right ovarian vein terminates directly into the inferior vena cava, just inferior to the renal vein, but 10% may drain directly into the renal vein. And the left ovarian vein terminates into the left renal vein at what typically is about a right angle. When you look at the common external and internal iliac veins, I think most of what's interesting lies in the distribution of the internal iliac veins. But let's not ignore the common and external iliac veins. The common iliac vein receives flow from the ascending lumbar vein in addition to the internal and external iliac veins. The ascending lumbar vein runs cranially along the spine to collect blood from the lumbar veins and the left renal vein. It then forms the origin of the azygous vein on the right and the hemiazygous vein on the left. The external iliac vein receives blood from the common femoral vein in addition to the deep circumflex iliac vein and the inferior epigastric vein. The internal iliac veins receive blood from 3 different groups of veins. First, there are the parietal tributaries. This includes the veins originating outside the lesser pelvis, which are the superior and inferior gluteal veins, the internal pudendal vein, and the obturator vein. The parietal tributaries also include the veins originating from the walls of the lesser pelvis. These include the lateral sacral veins and the sacral venous plexus. There are also visceral tributaries, which originate from the venous plexuses that drain the pelvic organs. And these include the rectal venous plexus, both an external and internal venous plexus, the vaginal venous plexus, the vesical venous plexus, and the uterine venous plexus. What really makes this interesting are the complex connections that exist between these different systems of veins. So one example is the left renal vein to the common iliac vein via the ascending lumbar vein. Another example is between the uterine plexus and the ovarian plexus. And finally, there's connections between the pelvic veins and the superficial veins of the leg, which is why these superficial veins of the leg are included in this whole discussion. The inguinal, obturator, pudendal, and gluteal veins from the pelvis communicate through the pelvic floor with veins of the thigh, perineum, and buttocks. And these connections are known as escape points, and they could be responsible for some of the manifestations of pelvic venous disease. In general, the manifestations of pelvic venous disease depend on the source and location of the primary abnormality and the balance between venous reflux and venous obstruction, both of which can lead to abnormal venous dilatation. Understanding why the symptoms are occurring will help direct you to the most appropriate treatment for this condition. So let's talk first about reflux. And reflux can occur for several different reasons. The first relates to the anatomy of the venous system. When it comes to the ovarian component of the pelvic veins, the left ovarian vein is more commonly involved, presumably because it joins the left renal vein at a right angle, which I mentioned before. And this configuration may facilitate reflux. When the right ovarian vein is affected, its junction with the inferior vena cava is usually anomalous. Incompetent valves within the gonadal veins are also responsible for reflux. Congenitally, the cephalad portions of the right and left ovarian veins lack valves in 6 to 15% of patients respectively. The valves are incompetent in greater than 40% of people. And when you look at the iliac veins, only 10% of those veins have valves. There can also be acquired reasons for gonadal vein incompetency. During pregnancy, for example, the vascular capacity of the ovarian veins increases up to 60 times their normal value. And this increased capacity causes distension which can last for months. And this can eventually contribute to venous incompetence and reflux. There may also be hormonal reasons why reflux occurs. Estrogen can weaken veins and cause venous dilatation through nitric oxide release, while progesterone weakens valves. Together, this can promote the development of incompetent ovarian and pelvic veins with subsequent reflux. People thought this might be the case because there's a high rate of associated polycystic ovaries when it comes to pelvic venous disease. And finally, some have attributed reflux to gonadal vein kinking. The weight gain and positional changes of the gravid uterus during pregnancy can cause kinking of the ovarian veins and subsequent venous congestion. Remember that obstruction is also a potential reason why these symptoms might occur. And it's important to know if there's an obstructive component to pelvic venous disease in order to direct treatment appropriately. In the case of obstruction, the dilated pelvic veins seen in these patients may actually be collaterals that have developed in response to the obstruction. Treating these collaterals without treating the obstruction can lead to worsening of symptoms. There are generally 3 conditions that we talk about in this setting. The first is May-Thurner syndrome. A left common iliac vein stenosis can redistribute flow into the internal iliac veins, the ovarian veins, and the ascending lumbar veins. And because of the increased hemodynamic load and the worsening of valvular incompetence, this can lead to venous dilatation, which contributes to symptoms. Nutcracker syndrome can also have a role. This is when the left renal vein is compressed between the aorta and the supramesenteric artery. This can be an incidental finding on asymptomatic patients, or it can be an important underlying problem in this setting. Clinical symptoms can include hematuria, proteinuria, and flank pain, and it can be seen in almost 20% of patients with pelvic venous disease. Finally, congenital or acquired IVC absence can play a role here as well. Acquired IVC absence is usually thought of in the setting of thrombosis of the inferior vena cava. These conditions are associated with multiple dilated collateral pathways which are responsible for draining blood from the pelvis and lower extremities. And these pathways may include the gonadal veins, which can lead to dilatation of these veins. So if you have reflux and/or obstruction, it can lead to venous hypertension, which has several different effects. It can increase tension in the vein wall. It can lead to degradation of the underlying endothelium and smooth muscle, which can cause a reduced ability of the vein to constrict and relax. and it can also trigger an inflammatory reaction which further promotes endothelial cell injury. All three of these consequences of venous hypertension can ultimately lead to venous dilatation. Remember that the ovarian and uterine veins may be particularly sensitive to the vasodilatory effects of estrogen, which is produced in the ovaries. All of this can lead to symptoms. And the symptoms experienced by the patient are going to depend on which venous beds are dilated and whether or not the dilated veins are decompressed. So let's first look at the ovarian vein and internal iliac veins. When reflux is occurring, the veins get dilated. And if the dilated veins are not decompressed, which is otherwise known as uncompensated physiology, it means that the dilated veins will probably result in chronic pelvic pain. But if the dilated veins are decompressed, potentially through escape points, which is known as compensated physiology, it means that there will be varicosities, maybe vulvar varicosities or lower extremity varicosities, without significant pelvic pain. Uncompensated physiology in the setting of left renal vein obstruction can lead to pressure transmission and symptoms referable to the left kidney, including flank pain and hematuria. But if the obstruction is compensated through reflux through the ipsilateral ovarian vein, it can lead to pelvic venous hypertension and pelvic varicosities, especially if there's no connection to the ascending lumbar vein. It can also lead to lower extremity and vulvar varicosities if there's additional decompression through the escape points. And in the setting of left common iliac vein outflow obstruction, uncompensated obstruction can transmit pressures back, and patients may have symptoms including lower extremity edema and or exercise-induced pain. Compensated obstruction of the left common iliac vein can lead to retrograde flow via the ipsilateral internal iliac vein, and this can lead to pelvic venous hypertension and pelvic varicosities, again with the possibility of lower extremity and vulvar varicose veins if decompression also occurs through escape points. So for now, let's focus on the symptoms that are related to uncompensated reflux in the ovarian and or internal iliac veins. Remember that reflux and obstruction leads to venous hypertension and venous dilatation. When venous dilatation occurs, you can stimulate pain receptors within the vein wall. You get neurotransmitter release, such as substance P, by the vein wall. And you also get compression of nerves against adjacent pelvic structures due to the venous dilatation. And this can all lead to pain. The pain in this setting is often exacerbated by prolonged standing, heavy lifting, intercourse, menstruation, and pregnancy. And it's usually most severe at the end of the day after the patient's been upright for most of the day. The pain can therefore be relieved when assuming a supine position. It also tends to abate after menopause. There are several associated symptoms. There are nonspecific symptoms including headache, bloating, nausea, and lethargy. There are pelvic symptoms including dysmenorrhea, dyspareunia, urinary urgency, vaginal discharge, and persistent genital arousal. There are venous-related symptoms including vulvar swelling, lower extremity swelling and varicose veins, a lower backache, rectal discomfort, and progressive hip pain with swelling. And there's a psychological burden to these symptoms, including increased levels of anxiety, stress, and depression. After the patient has been thoroughly clinically evaluated, the next step is usually some type of imaging exam. And ultrasound is usually the initial modality that's used to evaluate a patient with chronic pelvic pain. There are several diagnostic criteria used with ultrasound. The first is a dilated, tortuous parauterine vein with a diameter greater than 4 millimeters. The positive predictive value of this finding increases as the diameter of the vein increases. We also look for slowed or reversed flow in the ovarian vein, and flow reversal is highly sensitive. And finally, we look for a dilated arcuate vein that's greater than 5 millimeters and crosses the myometrium to communicate with pelvic varicosities. This particular finding has a low sensitivity but a high specificity. On CT, we look for the presence of at least 4 ipsilateral tortuous parauterine veins and at least one of those veins should be greater than 4 millimeters in maximum diameter. We also look for an ovarian vein diameter greater than 8 millimeters. You can usually see the tortuous periuterine varices very well on axial imaging. On coronal images, you can usually see the dilated ovarian vein as it makes its way from the renal vein down to the periuterine varices. MRI can be used as well. It can be used to evaluate gonadal reflux and pelvic varices, and it can detect retrograde flow in the gonadal veins with subsequent retrograde flow into the internal iliac vessels and pelvic varices. The nice thing about MRI is that it can be helpful for diagnosing other causes of chronic pelvic pain. A major issue, a problem with all of these imaging modalities is that they can identify pelvic varices in women who are asymptomatic. In those patients, the varices are an incidental finding. For example, almost half of asymptomatic Paris women have left ovarian vein reflux and enlarged mean ovarian vein diameters ranging from 7 to 12 millimeters on CT. Therefore, clinical context is important in determining the significance of this finding. There is a broad spectrum of pelvic vein dilatation. Some people have used this system to stratify patients. If the pelvic vein dilatation is less than 4 millimeters, it's normal. If the dilatation is between 4 to 8 millimeters, then it's likely associated with asymptomatic reflux. And if the pelvic or ovarian veins are greater than 8 millimeters in diameter, then this usually means that there's reflux associated with pelvic pain. And this can help identify patients who should be considered for venography and possible embolization. When it comes to venography, this can be performed from an internal jugular or common femoral vein approach. During the exam, all possible sites of venous disease should be studied, including the right and left common and internal iliac veins, the right and left gonadal veins, and the left renal vein. IVUS can be a helpful adjunct to this study by evaluating for possible May-Thurner syndrome or Nutcracker syndrome. Remember, the right ovarian vein may be difficult to find, and one trick is to observe the contrast passing across the midline from a left ovarian injection, because this can help identify the course of the right ovarian vein and where its confluence is with the inferior vena cava. On venography, there are several diagnostic criteria. We look for a diameter of at least 5 millimeters in the gonadal, uterine, and utero-ovarian arcade veins. We look for retrograde caudal flow in the gonadal vein and reflux of contrast across the midline to the contralateral side through the pelvic varices. We also might see opacification of vulvovaginal and orthi varices. And finally, we look for stagnation of contrast in the pelvic veins. And in general, if our catheter is sitting near the confluence of the ovarian vein and the renal vein, and you can see the venogram, the venographic appearance that is pictured on this slide, then this is abnormal because it's indicative of retrograde flow in the ovarian vein and filling of these varices. And these images show how the contrast can pass right across the midline into the contralateral pelvic varices and ovarian vein, as well as the internal iliac vein. Remember that a normal gonadal vein diameter on venography is less than 5 millimeters, and a diameter of 8 to 10 millimeters is considered abnormal. However, ovarian vein diameter may be a poor predictor of gonadal vein reflux. The absolute diameter should not preclude treatment in the presence of other findings. Once a symptomatic patient with pelvic varices and retrograde flow in the gonadal veins is identified, decisions need to be made about treatment. You can think about medical therapy. This is designed to treat pelvic venous disease as one occurring due to ovarian dysfunction and to address the associated pain. The rationale is that estrogen is a venous dilator and that counteracting this effect by suppressing ovarian function or increased vasoconstriction of dilated veins could potentially resolve symptoms. Medroxyprogesterone acetate has been shown to work in this setting. It acts as a progesterone agonist, causing an inhibitory effect on estrogen levels by suppressing the hypothalamic pituitary axis. Ultimately, this suppresses ovarian function. There are studies which show success in reducing pain that's limited by adverse effects such as weight gain and bloating. Gonadotropin-releasing hormone analogs have been used as well. They've shown to improve pelvic symptoms and that this effect can last for 1 year after 6 months of treatment. But there are limitations due to side effects, cost, and the lack of feasibility of long-term use due to the risk of menopausal symptoms and osteoporosis. The effects of medical therapy are thought to be transient, but it may be helpful for patients with mild to moderate symptoms who would like to delay endovascular or surgical treatment. Surgery is also considered in this setting, but a hysterectomy with removal of the ovaries doesn't provide long-term symptom relief and has a higher cost and morbidity compared with minimally invasive treatment. Before discussing the role of embolization in sclerotherapy, it's important to always remember the potential obstructive component of pelvic venous disease. If this is discovered on imaging, it will need to be addressed for the symptoms of pelvic venous disease to be treated successfully. In patients with Materna syndrome, stent placement can be used to treat associated symptoms. The restoration of blood flow in the common iliac vein was found to be associated with a decrease in severity of the symptoms when combined with embolization of the gonadal veins. This eliminated symptoms in over 80% of patients. For patients with nutcracker syndrome, left renal vein transposition is usually performed to treat these patients, although stent placement is being used more commonly today. One thing to remember about stent placement is that migration of the stent is a known risk of using stents in this location. Embolization is actually the most effective technique for treating patients with symptomatic parauterine and paraovarian varices secondary to reflux. Technically, coils and plugs are typically used for the embolization component of this procedure. There's no difference in pain relief between the use of coils and plugs, although radiation doses are lower when plugs are used. Treatment of the entire length of the ovarian vein, starting just above the deep pelvic plexus, is recommended when performing embolization. This is done to prevent residual incompetent patent segments from collateralizing with retroperitoneal veins and reconstituting the reflux circuit. Coil deployment techniques can vary among people performing this procedure. Some prefer tight packing at various points along the length of the ovarian vein, while others feel that tight packing is not necessary to induce the foreign body reaction that will ultimately lead to venous occlusion in this setting. Here's just an example of a case of pelvic venous disease where we performed a left gonadal vein embolization, and it's very common for us to use a combination of coils and plugs during these procedures. In 2002, Tony Van Brooks published his experience with embolization combined with sclerotherapy to treat pelvic venous disease. In this study, procedures were staged with ovarian vein embolization and sclerotherapy, followed by the same treatment in the internal iliac vein with a balloon occlusion catheter, and significant improvement in pain was achieved. After this paper was published, sclerotherapy became a routine part of treating these patients, and some argue that it's the most important part of this procedure. Sclerotherapy increases the likelihood that branches of the major veins will be treated. When sclerotherapy is administered below the confluence of the ovarian and internal iliac trunks, it might better address the rich anastomoses in the utero-ovarian arcade, and it will also treat the distal pelvic venous reservoir. Detergent-based sclerosants act on the lipid molecules in the cells of the vein wall, and this causes intimal inflammation and thrombus formation, which then leads to sclerosis and complete vessel occlusion. STS is commonly used as a foam which spreads over the endothelium so there is larger surface contact. There are several different approaches to sclerotherapy. One approach is to perform sclerotherapy from a distal catheter position in the ovarian vein before coil embolization is performed. Another approach is to perform sclerotherapy from the internal iliac vein using an occlusion balloon. The volume of sclerosant used in this technique should penetrate the varicosities without undue spillage from the drainage channels. And others may use a sandwich technique when the sclerosant is placed in between proximal and distal coils or plugs. After the procedure, patients are usually able to resume usual activities within just a few hours. They may experience some transient, mild paraspinal and pelvic discomfort from the phlebitis caused by the sclerotherapy and the embolization agents, and this is usually managed with oral NSAIDs. Patients may also describe some deep pelvic discomfort, which reminds them of their typical symptoms, and this could last for approximately 5 days, but it does abate quickly after that. So let's talk about outcomes. The good news is that embolization with or without sclerotherapy results in symptomatic improvement. There have been at least 2 meta-analyses performed. Daniels reviewed 21 prospective case series in 1 randomized controlled trial in over 1,300 patients, and Mahmoud reviewed 20 prospective case series in just under 1,100 patients. And what these showed in terms of early outcomes was that 75 to 88% of patients had early and substantial pain relief, with about 12% reporting little or no improvement. And in terms of late outcomes, meaning after 6 months, 87% had symptomatic relief, with 13.5% reporting little or no relief. Embolization can also result in long-term symptom control. And Kim reported an 83% improvement in overall pain perception at a mean follow-up of 45 months. And Laborda demonstrated a 94% clinical success rate and complete symptom resolution in 33% of patients at 5 years. The other good news is that embolization seems to have little impact on fertility. There's no significant difference in FSH, estradiol, and LH levels at baseline and at both 6 and 12 months after embolization. And successful pregnancies and deliveries have been reported after embolization. The bad news is up to 18% of patients report symptomatic recurrence over a range of 4 to 12 months. If patients don't experience symptom improvement during the initial 3 months, no improvement should be expected later. In addition, there are no consistent predictors of outcome after embolization. Parity, size of the varices, severity of the symptoms, or the territory that's embolized all do not independently predict outcome. Finally, there's really no standardization as to how this condition is defined, diagnosed, treated, and reported. Unfortunately, different studies have used different ways to assess outcomes. They've looked at pain, severity of lower extremity varicosities, imaging outcomes, etc. In addition, different studies have evaluated different techniques, including embolization alone, embolization with sclerotherapy, unilateral or bilateral embolization, ovarian vein embolization with or without internal iliac artery embolization, and so on and so forth. The quality of the studies reporting outcomes after embolization is also considered to be low, and there's generally no direct comparative evidence against no embolization. A lot of people do talk about the one prospective randomized controlled trial that's out there. This study looked at 118 patients who were randomized to undergo embolization or hysterectomy with bilateral oophorectomy plus hormone replacement, or hysterectomy with unilateral oophorectomy on the predominantly congested side. This study showed that the embolization group and the TAH bilateral oophorectomy group had statistically significant improvement in pain based on visual analog scores at 3, 6, and 12 months. The issues are that the method of randomization used in this study was unclear. There were substantial post-randomization exclusions, which undermined the credibility of the trial results, and the assertions of the study have never been replicated. These challenges have to be overcome in order to develop uniform ways to study the condition and the techniques used to treat these patients before definitive conclusions can be made. Back to the positive side is that complications occur, but they're very rare. Immediate complications include hematoma, non-target embolization, vessel perforation, local thrombophlebitis, and stroke even related to paradoxical emboli, but these are rare. And delayed complications can include coil migration. This is more likely to occur with embolization of the internal iliac veins than the ovarian veins, and when it occurs, coils typically migrate to the pulmonary arteries. If it's one small coil, it usually can be left in place with any adverse sequela from it, but a lot of times attempts are made to retrieve these coils. Probably the biggest issue when it comes to pelvic venous disease right now is reimbursement. And there are several insurance companies that have policies which state that embolization of the ovarian or internal iliac veins is considered unproven and not medically necessary for treating the symptoms of pelvic venous disease. This is, of course, evolving, and I've seen it improve over the past few years, but it does speak to the fact that we have more work to do. We have to define the disease. We have to define and classify the symptoms associated with this abnormality to better understand how they specifically relate to the underlying etiology. And we have to define which patients will potentially benefit from treatment and understand why treatment fails in some patients. People talk about the need for randomized controlled trials, but until all of these other things are worked out, this is not likely to happen or happen in a way that will generate useful information. In conclusion, pelvic venous disease is an entity that should be considered in a patient with chronic pelvic pain. Endovascular treatment can be effective for patients suffering from this condition. Further study is needed to better understand this disease and how we are able to help.